Good evening, everybody, and thank you, sir, for having me as part of this very unique and interesting session. So, from retina and the inner part of eye, we now move out to the external part of the system, and I'll be talking about orbital cellulitis. Now, orbital cellulitis is actually the term which is used to describe orbital inflammation, which is caused by pathogenic organisms. Now, these pathogenic organisms can be bacteria, fungi,
Boss, can you
or
maximize your slide? Can you increase this thing?
okay, yeah. Is it okay? Is it okay now? Yeah. So these inflammations can be caused by either bacteria or fungi, or sometimes rarely tuberculosis or parasitic infestations, which are not uncommon in our setup. Now, these are potentially vision and life-threatening conditions, one of the few real medical emergencies in ophthalmology where life is at stake. The incidence has been reported to be more frequent in children than in adults in various studies which have been conducted across the globe. And So the incidence, if you look at it as per the data, it is quite infrequent. But in an emergency clinic, in ophthalmology emergency clinics where we were, these form a substantial part of the emergencies that we see, and some things which require a prompt diagnosis and management. Now, the source of infection in most of these cases can be attributed to contiguous inflammation, which comes from the surrounding structures, that is, from the sinuses, face, or the oropharynx. Then the just a moment, my slides are stuck. Yeah. So then you can have a history of trauma, which may have led to direct infiltration of the orbit with some bacteria or some microbes. Thirdly, there can be some foreign body which may be lodged in the orbit, particularly the organic foreign bodies, which have a high chance of having a polymicrobial type of growth over their surface, which can lead to a severe kind of an orbital cellulitis. And lastly, it can be a hematogenous spread, which is less common. Now, let's see few clinical situations and try to understand how orbital cellulitis can have varying presentation and different ways of in which it can affect. Now, this lady presented with periocular swelling of the right eye. There was swelling, there was pain, there was lid edema. But the important thing here, if you examine such patients, is ask them to rotate their eyeballs in all the gazes. And here the extraocular movements were full. There was no proptosis. And if you image these patients, as you can see a CT scan of this particular patient, you see that the inflammatory material is deposited in the anterior part of the orbit, or rather, more accurately, if we described, into the preseptal plane. Now, the orbital septum somehow acts as a mechanical barrier to the posterior extension of infections to some extent. And so, in such a situation where you have this kind of a clinical picture with the imaging showing that the infection is limited to the anterior part of the orbit, beyond the septum, preseptal, their oral antibiotics are usually enough. Another patient who has a more severe presentation with a lot of edema, a lot of erythema on the eyelid, mechanical ptosis happening here, and things look a little more worse than the first patient that we just saw. In this patient, one would suspect possibly there is some sort of orbital involvement as well. But when this patient was imaged on the CT scan, you see that luckily he does not have any posterior extension of the infection, and it is mainly a loculated, well-defined abscess formation, which is still confined to the preseptal part of the orbit. So this is again a manifestation of preseptal cellulitis. In cellulitis, where you have a more diffuse involvement of the preseptal tissues, in preseptal abscesses, you have a liquefaction or the pus formation, which remains confined to the preseptal part. You can treat it with oral antibiotics, but this kind of a picture would require a surgical drainage for sure. Now compare the previous two patients with this patient. In this particular patient, a young girl who presented with a recent onset of swelling around the eyes, you can probably make out that the orbit is a little more tense in this situation. So we have lid edema on both the upper and lower lids. You can make out slight amount of chemosis here and ask the patient to move the eyes in all these situations. And if the patient is having painful movements, there is limitation of movement. In the initial phases, it's just a painful movement of the eyes, which gradually progresses to limitation of movement. And you see, you get this patient's imaging done, and what you see here on this MRI is number one, there is opacification of sinuses. So there is ethmoid sinus which is full, there is a maxillary sinus which is full, and there is a lot of infiltration into the medial and the inferior part of orbit here. So this is a situation where the infection has gone into the orbit, posterior part of the orbit. So this is a case of orbital cellulitis or frank orbital cellulitis, as uh, we are supposed to be discussing. Another patient uh, who presented with proptosis, lid edema, and chemosis, unable to close the eyes. You see the air bubble in the anterior chamber. So sometimes these infections can even be iatrogenic. Now, this patient was operated for a DSEC surgery, and the next morning when the pad was opened, this the patient was in severe pain. Patient landed up in emergency, and this was the picture. So you see here what has happened is with the peribulbar block, there is it has got some sort of contamination and which has led to infection in the orbit. So looking at the CT scan, you can see that there is a lot of haze in the superior and the lateral part of the orbit. The scan is not of very good quality, but there is a lot of this fat infiltration, what we call as fat streaking in the posterior part of the orbit. There is a lot of proptosis. Fortunately, with IV antibiotics, most of these cases respond well. Another patient who presented with similar presentation, the orbit looks tense, there is proptosis, there is a swelling of the upper and the lower eyelids, there is pain, there is diminution of movements when you try to force open the eyelids. In addition, the patient also has a high grade fever. So obviously, it looks like orbital cellulitis clinically, but radiology plays a very important role in differentiating the various subtypes of orbital cellulitis. Now, in this situation, the MRI showed that the medial part of the orbit was involved. There was ethmoid sinusitis on both sides. There is infiltration of the medial part of the orbit. The soft tissues appear hyper intense here. But at the same time, what you see here is a hypo intense collection or rather a hypo intense area. And this is like, surrounded by something which is convex, convex towards the orbit, adjacent to the medial wall of the orbit. So this is a subperiosteal abscess formation. It is important to get imaging done in all these patients so that you don't miss out on these critical signs. Most of these cases, as previously I mentioned, the infection comes from the sinuses. And because the medial wall of the orbit and the inferior wall of the orbit are the thinnest of the walls, and so it's easier for the infections to traverse the microorganisms to traverse through these walls, through foramina, through the neurovascular bundles, along the neurovascular bundles, and so it can, and plus the orbit is a closed space, so sometimes there is a collection of pus underneath the periosteum, which is like this periosteal abscess, subperiosteal abscess. I'll be talking about the management subsequently. Another presentation where this young chap presented with obvious limitation of the movement in upgaze. There was a lot of chemosis, a lot of periocular edema, and intense pain, fever. Now, when you image this kind of a patient, which you can see here, the CT scan done here, it shows a lot of haziness, lot of a kind of a mass kind of a thing in the superior orbit. It's not exactly a tumor or something. If you notice carefully, there is this hypodense area surrounded by a hyperdense uh, adjacent tissues. So this hypodense area, this is how actually an orbital abscess in the initial stage can look like sometimes. You go looking in for a perfectly hypodense, round, cystic kind of a lesion. It may not appear so in the initial phases. It may just look like this. And once the pus liquefies, then you get those perfectly hypodense pus type of lesions in the orbit. Now, having an abscess in the orbit is a really serious condition, and this kind of a picture should never be missed. One should always get an imaging done because of what may follow, particularly in a situation like this where you have this child who presented with the superior orbital fullness, erythema, pain on movements, and fever. On imaging shows again a similar kind of diffuse hyperdense kind of shadow in the superior part of orbit. But what you see here, notice carefully that the superior wall of orbit has been breached, and actually the abscess has invaded the brain. So this is a very, very serious condition where you will also have to involve a neurologist and a neurosurgeon. You have to drain the abscesses which have been formed now. So it's really a tricky area because many a times we see patients who've been treated with oral antibiotics and they are kept on oral antibiotics for long without any imaging done. And when they land up, they sometimes land up with a situation like this, which can even be fatal if the infection goes deep into the brain. Particularly the abscesses in the orbit, which are formed in the superior part of the orbit. If the medial and the inferior part is involved, of course, it's not that critical, of course, because of the veins and going into the cavernous sinus, it's still important, but this part is most dangerous. Now, again, this patient, as I was mentioning, was kept on oral antibiotics for about a week or so after he developed the symptoms, but the symptoms were rapidly progressing. The patient was still on oral augmentin and stuff like that. And when he landed up, he had all the classical signs: proptosis, chemosis, extraocular movement restriction, high fever, headache. In addition, he was not oriented properly to the surroundings. His consciousness appeared a little deranged and he was drowsy. In such situations, it's a dire emergency. You should refer the patient immediately for imaging. And what you see here in this patient is a dilated superior ophthalmic vein. And look at the cavernous sinus. Compare it with the cavernous sinus on the contralateral side, and you see there is dilatation of cavernous sinus on this side, affected side. So what we have here is one of the most dangerous complications of orbital cellulitis, that is the cavernous sinus thrombosis. So all efforts should be made that a patient with an infection of the lids or orbit should not go into this stage, as it's really very difficult to manage the patients at once they reach this point. There is almost 20% risk of death and vision loss. So all these changes can happen in the eye when you have orbital cellulitis. Orbital cellulitis can damage the various tissues of the eyeball. Number one, cornea can get exposed and it can lead to exposure keratopathy. There can be secondary glaucoma. There can be septic uveitis and retinitis. There can be exudative RD. There can be optic neuropathy caused by direct pressure effect of the proptosis and the surrounding edematous tissues, or it can be an ischemia of the optic nerve, which leads to optic neuropathy. And it can even lead to panophthalmitis with when you see a lot of if you see a patient of panophthalmitis and then you get a CT and you see there is fat sticking in the orbit sometimes. So it can be a concurrent thing. So treatment is mainly broad spectrum antibiotics. We try to cover both gram positive and gram negative bacteria. We start with a third generation cephalosporin and an aminoglycoside combination intravenously in orbital cellulitis cases, and observe for 1 or 2 days. If the patient improves, it's fine. Otherwise, we also add metronidazole for anaerobes. Some ENT specialists add metronidazole kind of or tinidazole in the beginning itself if there is a lot of sinusitis. MRSA cases have been increasing of late, and if your patient is not responding to the routine antibiotics, then you must consider MRSA as a possibility. If you can get some material from an abscess for culture and it shows MRSA, or if the routine treatment is not being effective, you can switch to vancomycin. And once the initial upswing has been stalled by giving IV antibiotics, then IV steroids have a significant role, which we normally start after 48 hours to 72 hours of starting antibiotics. And what it does is it actually reduces the tissue damage which can be caused just by inflammatory process itself, and it helps in quicker resolution of the edema. It helps in quicker resolution of all the signs and symptoms, and it also helps to protect the nerve from the inflammatory mediators. So once the acute infection you feel has been um, kind of acute infection has been taken care of, the disease is on a downswing, then adding steroids is not a bad idea. Surgical management is required if there is an abscess formation, whether subperiosteal abscess or an orbital abscess or an intracranial abscess. And if there is a sinuses which are full and leading on to orbital cellulitis, FES can be done and sinuses need to be cleared up. On the third situation where surgical management is required in a patient of orbital cellulitis is a foreign body removal if there is a lodged foreign body, particularly an organic one, which may sometimes be difficult to diagnose initially. Now, abscess drainage is not required in all the patients an orbit of a subperiosteal or orbital abscess, particularly in children. Children lesser than 10 years of age are assumed to have or have been shown to have rather simple bacterial infections which respond well to IV antibiotics. And in these cases, usually just the medical treatment works. But if you have a patient older than, let's say, 10 years or a patient who's not responding well to IV antibiotics, then you need to go for abscess drainage. Obviously, if there are severe signs present like compromised vision, pupillary changes, raised IOP, if there is proptosis of over 5 millimeter, and patients who have optic nerve compromise from compression by the abscess, then obviously this is an indication for an early drainage of the abscess. So this is in nutshell about the treatment of orbital cellulitis, bacterial orbital cellulitis. The discussion would be incomplete if I don't talk about orbital cellulitis, which becomes a unique situation in diabetics and immunocompromised. Now, in these patients, you have to be very vigilant, as it may actually be a sign of an underlying mucormycosis or a sinonasal aspergillosis or a fungal infection. I'll be talking about mucormycosis here, which is more likely to be confused with an bacterial orbital cellulitis. So what happens is that mucormycosis comes from the sinuses most of the times, and the infection invades from either maxillary or the ethmoid sinus. It's a very fulminant infection which rapidly increases to involve all the tissues of the orbit diffusely. It attacks the vascular lumina, causes ischemic necrosis of the orbital tissues. You may see black ischar formation on the eyelids or the periocular tissues. And the patients are usually sick. Patients are usually in ICU. They land up in ICU fairly rapidly. They have underlying metabolic disorders. They have an uncontrolled diabetes. So all that needs to be taken care of. And once you examine, you have to see how severe the problem is. You have to do a CT scan or an MRI scan to assess the orbital invasion. And also, don't forget to look at the fundus in all cases of orbital cellulitis, particularly in this situation where you have a patient who's a diabetic. And if you find a central retinal artery occlusion, in these cases, it's invariably mucormycosis in a bad diabetic, if it's a bad diabetic case. The treatment starts with a biopsy, which proves the presence of fungi, and biopsy is usually done by the ENT specialist. They go into the sinuses, maxillary or ethmoid sinus, take out tissue which you evaluate. And once you have evidence in favor of mucormycosis, then an extensive surgical debridement or even orbital exenteration may be needed. Of course, the treatment is started with intravenous amphotericin B, but you can't wait for too long. If the response is not good in 24 to 48 hours or 72 hours at the most, then you have to take a decision as to, and the condition is still progressing, you have to take your call whether you want to go for surgery or continue with the medical therapy. And most often, uh, uh, if the problem is not responding well to amphotericin B, then you should not wait too long and you should go in. Also, local irrigation with ampho B has been recommended. Hyperbaric oxygen, etc., are other supportive factors which you need to consider. Obviously, diabetes, needless to say, diabetes has to be kept under control. Lastly, orbital cellulitis may not always be orbital cellulitis, and you have to keep in mind the differential diagnosis. Some of the more serious ones are retinoblastoma, which may sometimes have an extraocular extension, which may mimic an orbital cellulitis, or it may just be an advanced kind of an retinoblastoma or a group E retinoblastoma, which causes inflammation of the orbital tissues. And in those cases, you give steroids for some time and see for the inflammation if it responds, and then you plan your chemotherapy accordingly. Rhabdomyosarcoma cases are known to present rapidly, and sometimes they may mimic an orbital cellulitis. But if your orbital cellulitis kid is not responding well to IV antibiotics, then do consider an alternate diagnosis and consider biopsy without further delay. Sometimes necrotic melanomas of the choroid have also we've also seen that they present with symptoms similar to orbital cellulitis. When you image and when you look at the fundus, you see that the pathology lies elsewhere. Acute leukemia, acute T cell lymphomas have also been known to mimic orbital cellulitis and very rarely metastasis. So to summarize here, it's a real medical emergency and site threatening. It's important to know about the condition. It's important when to go for imaging and when to refer, because any delay on this part may actually lead to loss of sight for the patient, and particularly in patients like who are diabetics or immunocompromised compromised, it may lead to loss of life also. And you often require a team of an ophthalmologist, a good physician, an ENT specialist, and in more severe cases, neurologist or a neurosurgeon. Thank you very much.